In diabetes mellitus, the body has trouble moving glucose from your blood into the cells. So, blood sugar levels are constantly high. Insulin stimulates the movement of glucose into the cells, and glucagon stimulates the movement of glucose into the blood. In type 1 diabetes, the blood glucose stays high because of an autoimmune destruction of the pancreas, which leads to low insulin levels. In type 2 diabetes, the body makes insulin, but the cells are insulin resistant, meaning that they don't respond to insulin by taking glucose in. A cell's inability to use insulin translates in classical symptoms of diabetes like polyuria, where an individual pees a lot, polydipsia, where they drink a lot of water, sometimes polyphagia, where they eat a lot, and unexplained weight loss. Both type 1 and type 2 diabetes get these symptoms. However, with type 1, the onset is usually abrupt and usually affects people under 30. With type 2, the symptoms gradually worsen over a few months, and individuals usually have risk factors like being over 45 years old, having a first-degree relative with type 2 diabetes mellitus, a body mass index, or BMI, of over 25, a sedentary lifestyle, or cardiovascular disease, like hypertension. Now, type 2 diabetes accounts for about 90% of the diabetes cases, so let's start there. Diagnosing type 2 diabetes relies on determining blood sugar levels using one of four tests. The first and most common test is a fasting glucose test, and that's where a person doesn't eat or drink anything except water for 8 hours. Levels of 100 milligrams per deciliter to 125 milligrams per deciliter indicates prediabetes, and a level of 126 milligrams per deciliter or higher indicates diabetes. Usually, this test is done twice, and two results over 126 milligrams per deciliter are sufficient to diagnose a person with diabetes. Second, we have the oral glucose tolerance test, and that is where a person is given 75 grams of glucose, and then blood samples are taken at time intervals to figure out how well it's being cleared from the blood. At the time interval of 2 hours later, a level of 140 milligrams per deciliter to 199 milligrams per deciliter indicates prediabetes, and a level of 200 or above indicates diabetes. However, these two tests have one shortcoming. They only show what's happening to blood glucose levels in that particular moment in time, so we have no idea how long blood sugar levels have been high. This is where our third test comes in, the HbA1c, which is the proportion of glycated hemoglobin in the blood. When blood glucose levels stay high for too long, glucose begins to stick to proteins that are floating around in the blood or in cells, like hemoglobin. HbA1c levels of 5.7% to 6.4% indicate prediabetes, and 6.5% or higher indicates diabetes itself. Since red blood cells and hemoglobin typically hang around in the blood for up to 4 months, this test reflects blood glucose levels over the past few months. Finally, there's our fourth test, called a non-fasting or random glucose test, which can be done at any time. A red flag for diabetes is when this test shows a blood glucose level of 200 milligrams per deciliter or higher in an individual that has classic symptoms, like polyuria or polydipsia, or a hyperglycemic crisis. Of these, fasting blood sugar and HbA1c levels can also be used to screen people for diabetes. Guidelines recommend that screening begins at 45 in asymptomatic adults with no risk factors using either the fasting blood sugar or an HbA1c test. But screening can begin earlier if risk factors are present. Specifically, individuals who are overweight or obese or have a family history of diabetes mellitus can be screened starting at any age, as well as overweight or obese individuals assigned female at birth who are planning a pregnancy. Additionally, individuals with a personal history of gestational diabetes mellitus should have lifelong screening once every 3 years. If screening is negative for both diabetes and prediabetes, one of those tests should be repeated every 3 years. Alternatively, if prediabetes is detected, screening should be repeated yearly. Now, with type 1 diabetes, individuals typically present with sudden onset of polyuria, polydipsia, polyphagia, and unexplained weight loss, as well as high blood sugar. In order to differentiate type 1 from type 2 diabetes, we need to look for autoantibodies directed at glutamic acid decarboxylase, or GAD antibodies, and islet cells, or ICA2 antibodies. Finally, insulin deficiency can be checked using C-peptide levels. C-peptide is a molecule that's cleaved off from proinsulin when it's converted to insulin. So, low C-peptide levels reflect an insulin deficiency. In both type 1 or type 2 diabetes, it's important to think about chronic diabetic complications. Persistently high blood glucose levels can damage arterioles, primarily affecting the eyes, the kidneys, and the nerves. In the eyes, diabetes can lead to retinopathy, and evidence of that can be seen on a fundoscopic exam that shows cotton wool spots or flame hemorrhages, and can eventually cause diabetic retinopathy and blindness. In the kidneys, the afferent and efferent arterioles, as well as the glomerulus itself, can get damaged, which can lead to diabetic nephropathy. For this, a urine sample is used to screen for proteinuria, the presence of which reflects small vessel damage. Finally, nerve damage causes a decrease in sensation in the toes and fingers, sometimes called a stocking glove distribution, as well as causing autonomic nervous system dysfunction affecting everything from sweating to passing gas. Finally, both the poor blood supply and nerve damage can lead to foot ulcers that don't heal quickly and can get pretty severe, even requiring amputation. Now, in terms of treatment, there are 3 clinical scenarios: prediabetes, type 2 diabetes, and type 1 diabetes. For pre-diabetic individuals, the goal is to bring the HbA1c levels below 5.7%. And to do this, recommendations are mainly lifestyle changes over a 16-week trial period, like losing weight, sticking to a healthy diet, exercising, and quitting smoking. Specifically, we're talking about losing 7% of total body weight over 16 weeks, which can be done by decreasing caloric input by 500 to 1,000 kilocalories per day, depending on starting weight, and sticking to a diet rich in fruits and vegetables and low in sweetened sugared beverages and processed sweets, and also low in saturated fats like those found in meat and dairy products. So, less of the fast food style soda, hamburgers, and fries, and more home-cooked meals like roasted vegetables over lentils and rice, which is also cheaper as well. Finally, exercising means gradually increasing physical activity up to at least 30 minutes a day, at least 5 days a week. So, brisk walking, jogging, swimming, going to the gym, you name it. Whatever gets the blood flowing is good. In addition, sometimes metformin, a biguanide, is started in these individuals. Metformin works by making cells respond better to insulin, therefore decreasing insulin resistance. Unfortunately, metformin can cause nausea and diarrhea, and in rare situations it can cause lactic acidosis, particularly in individuals with chronic kidney disease and severe heart failure, so metformin is contraindicated in those situations. Metformin can also deplete vitamin B12 levels, which can lead to anemia. So, individuals on metformin need to get B12 levels checked and need supplementation if they're low. They also need a complete blood count, or CBC, with each evaluation to track changes in hemoglobin and hematocrit. For type 2 diabetes, the approach depends on HbA1c levels. For HbA1c levels between 6.5% and 10%, the initial approach is the same as prediabetes: lifestyle changes and metformin. Metformin is available in 500, 850, and 1,000 milligram tablets, and therapy usually starts with a 500 milligram tablet, once daily with the evening meal. If well tolerated, a second 500 milligram tablet can be added with breakfast. Doses can be increased by 1 tablet once every 1 to 2 weeks, up to the usual effective dose of 1,500 to 2,000 milligrams per day. However, follow-up is a bit more intensive here, so HbA1c levels are checked again every 3 months. And generally speaking, the goal is to keep the HbA1c level below 7%. If the HbA1c is still higher than 7% after 3 months of metformin, a second anti-diabetic medication is usually used, and there are several options to choose from. Which one is best depends on several individual factors, like whether or not the person is overweight, has chronic kidney disease, or severe heart failure, or atherosclerotic cardiovascular disease, defined as coronary heart disease, cerebrovascular disease, or peripheral arterial disease presumed to be of atherosclerotic origin. It's also important to factor in the risk of hypoglycemia that some of these medications pose. Okay, so first there are the sulfonylureas, like glimepiride and glipizide. These medications increase the amount of insulin that the pancreas naturally releases, but they can cause hypoglycemia as well as weight gain. As a result, individuals should take these medications 30 minutes before a meal. Like metformin, sulfonylureas are also contraindicated in individuals with chronic kidney disease. They may, however, be given to individuals with heart failure. Next up are the thiazolidinediones, like pioglitazone, and they help reduce insulin resistance, like metformin, as well as hepatic gluconeogenesis, meaning that they make the liver make less glucose while fasting, overall lowering blood sugar. However, these medications can also cause weight gain and are contraindicated in individuals with heart failure. On the flip side, studies have shown that they could improve cardiovascular health in people with atherosclerotic cardiovascular disease. Next are the SGLT2 inhibitors like dapagliflozin, which inhibit a sodium glucose cotransporter in the kidneys, leading to increased urinary excretion of glucose and lower blood glucose levels. These drugs can help with weight loss, and they have also demonstrated beneficial effects on cardiovascular health in people with atherosclerosis. However, they are contraindicated in people with severe chronic kidney disease. Also, there's a minor risk for hypoglycemia, in case too much glucose is lost in the urine. Finally, there are two other classes of anti-diabetic medication. These are glucagon-like peptide 1 or GLP analogs, which are injected subcutaneously, and dipeptidylpeptidase 4 or DPP4 inhibitors, which are taken orally. GLP-1 is a hormone secreted by the gastrointestinal tract after a meal that decreases glucagon levels and increases insulin production, causing blood sugar levels to fall. DPP4 is the enzyme that degrades GLP-1 in between meals. So GLP-1 analogs, also called incretins, act like GLP-1 and lower blood sugar and cause weight loss. However, they are contraindicated in severe chronic kidney disease. Examples of incretins are exenatide and liraglutide. Liraglutide is specifically useful in people with atherosclerotic cardiovascular disease and also for diabetic nephropathy, because it slows progression of that disease. DPP4 inhibitors, also called gliptins, stop the degradation of endogenous GLP-1 to keep blood sugar low, but they do come with a small risk of hypoglycemia. They can't be given in heart failure. But the good news is that they can be used for individuals with severe chronic kidney disease. So to wrap up quickly on these medications, the risk for hypoglycemia is high for sulfonylureas, low for SGLT2 inhibitors and DPP4 inhibitors, and next to zero for the other medications. As for the effect on weight, sulfonylureas and thiazolidinediones cause weight gain, GLP-1 analogs cause weight loss, and the rest have a neutral effect. People with severe chronic kidney disease can be given thiazolidinediones or DPP-4 inhibitors. For those with heart failure, sulfonylureas, SGLT2 inhibitors, and GLP-1 analogs are good options. Finally, individuals with atherosclerotic cardiovascular disease might benefit from thiazolidinediones, SGLT2 inhibitors, and one particular GLP analog, liraglutide. Alright, now let's go through an example. Let's say a person with type 2 diabetes presents with an HbA1c level of 8.5%. The first step would typically be lifestyle changes and metformin treatment. 3 months later, if HbA1c levels are still above 7%, then a second agent is added. For instance, a sulfonylurea, like glipizide. However, if the person is severely overweight and has diabetic nephropathy, we might opt for a GLP-1 analog like liraglutide instead of sulfonylurea to help with weight loss and slow the progression of diabetic nephropathy. Okay, now if 3 months after double therapy, which is to say 6 months after the initial diagnosis, HbA1c is still above 7%, then the recommendation is to add a third agent from the available anti-diabetic medications. Finally, if 3 more months pass, so 9 months after the initial diagnosis, and HbA1c is still above 7%, the recommendation is to initiate insulin treatment. Also, if the individual has an initial HbA1c level higher than 10%, then the recommendation is to start insulin therapy directly, just like in type 1 diabetes. There are a few types of insulin, and they're organized by their time to onset and how long their effect lasts. Rapid-acting insulins like Lispro, Aspart, or Glulisine act within 15 minutes and last for up to 5 hours. Short-acting insulins like human regular insulin act within 1 hour and last for up to 8 hours. Intermediate-acting insulins like NPH act within 2 hours and last for up to 18. Finally, there's long-acting insulins, like Detamir and Glargine insulins, that also act within 2 hours but last for up to 24. And then there are the pre-mixed combinations of these insulins. Most frequently, they're a mix of a rapid-acting insulin, like, let's say, Lispro, for example, with an intermediate-acting insulin like NPH. They come in preset concentrations like 70-30 or 50-50, where the first number is the concentration of NPH and the second is the concentration of the rapid insulin. When insulin therapy is started, usually a long-acting insulin like Detamir or Glargine is introduced first, starting at 10 units right before bedtime. Doses are then adjusted depending on the fasting blood glucose the next morning, which individuals can determine themselves using a glucometer, with a goal to keep fasting blood glucose between 80 and 130 milligrams per deciliter. If fasting blood glucose is constantly higher than 130 milligrams per deciliter, basal insulin doses should be gradually increased once or twice a week, until fasting blood glucose is less than 130. Likewise, if fasting blood glucose is lower than 80 milligrams per deciliter, basal insulin doses should be gradually decreased. If, after 3 months of using a long-acting insulin, HbA1c is still higher than 7%, then a rapid insulin can be added before the biggest meal of the day. Eventually, 1 or 2 more doses of rapid insulin can be added throughout the day, building up to an insulin therapy scheme called the basal bolus scheme. Now, because type 1 diabetes is insulin dependent from the start, the basal bolus scheme is also the standard of care for type 1 diabetes. So, with basal bolus, individuals administer 1 long-acting insulin before bedtime and a short-acting insulin 3 times a day before breakfast, lunch, and dinner. This attempts to mimic the way that the pancreas naturally releases insulin, but there's a risk for hypoglycemia. So to avoid that, individuals measure their blood sugar before each insulin shot and eat right afterwards. So, a typical day with the basal bolus scheme goes like this. Wake up, measure blood sugar, take rapid insulin, eat breakfast. Before lunch, measure blood sugar, take rapid insulin, eat lunch. Before dinner, measure blood sugar, take rapid insulin, eat dinner. Finally, before bedtime, measure blood sugar and take a long-acting insulin. A simpler alternative to the basal bolus scheme is to use 2 shots of pre-mixed insulin per day, 1 before breakfast and 1 before dinner. Finally, in a hospital setting, a sliding scale regimen may be used, which is where the dose of insulin is set according to how high blood sugar is. It's possible to do this in a setting where constant correction of blood sugar is possible, like giving a rapid insulin if blood sugar is too high and giving intravenous glucose if the blood sugar drops too low. However, this is not an ideal choice in an outpatient setting, because it's reactive rather than proactive regimen, and there's a risk for both hyper and hypoglycemia. Now let's go over the diabetic emergencies, starting with hypoglycemia, which is when blood sugar drops below 70 milligrams per deciliter, and this can happen in both type 1 and type 2 diabetes. It can happen if an oral anti-diabetic medication or insulin dose is too high, or because the individual took medication without eating much food. Other causes of hypoglycemia are exercising too much and eating too little, as well as serious infections. With mild hypoglycemia, early symptoms are weakness, hunger, shaking, and sweating. And it can be corrected by eating or drinking something rich in rapidly absorbing carbohydrates, like juice, sugar, or candy. Basically, all of the stuff you're normally told to avoid are now lifesavers. If the hypoglycemia worsens, it can lead to confusion, loss of consciousness, seizures, or even death. So, in a severely hypoglycemic individual who's lost consciousness, treatment is intravenous glucose as fast as possible. Alright, now another diabetic emergency that occurs more frequently with type 1 diabetes and can sometimes even mark the onset of the disease is diabetic ketoacidosis, or DKA. With DKA, there's high blood sugar, usually between 300 and 500 milligrams per deciliter, and a buildup of ketones in the blood, called ketonemia, and they make their way into the urine, causing ketonuria. And there's also acidosis, or a low blood pH. Clinically, individuals with DKA are dehydrated, and they can develop Kussmaul respiration, which is deep and labored breathing. Their breath also smells sweet and fruity. Nausea, vomiting, and in severe DKA, mental status changes and acute cerebral edema can occur. Basically, what you need to know is in DKA, the blood sugar is high, the blood pH is low, and there are ketones in the urine. Because of the acidosis, there's hyperkalemia, and because ketoacids are unmeasured anions, it results in a high anion gap. Treatment of a DKA episode involves giving plenty of fluids, which helps with dehydration, insulin, which helps lower blood glucose levels, and replacements of electrolytes, like potassium, all of which help to reverse the acidosis. In practice, the first step is administering fluids at a rate of 1 liter of saline per hour. If blood pH is below 7, intravenous bicarbonate can be given to reverse the acidosis. Then, if the potassium is below 3.3 milliequivalents per liter, administer potassium before insulin, and then give a 10-unit insulin bolus when potassium levels are above 3.3. Then, the person is started on a continuous insulin infusion, while monitoring potassium levels and the anion gap. An hour or two after the anion gap closes, IV insulin can be stopped. After that, administer a long-acting insulin, like glargine or detamir, subcutaneously and keep them under observation. Okay, now a final complication, which is specific to type 2 diabetes this time, is a hyperosmolar hyperglycemic state, or HHS. This is also a very high blood sugar situation, like over 800 milligrams per deciliter high, which leads to a serum osmolarity of over 320 milliosmoles. This can cause mental status changes ranging from confusion to coma and severe dehydration. There's usually no acidosis, ketonuria, or anion gap with HHS, but sometimes the pH can drop a bit and ketone levels may rise just a tiny bit as well. So technically there is a bit of overlap between DKA and HHS. Therefore, treatment of HHS is similar to DKA, giving the person insulin and plenty of intravenous fluids. They'll slowly get everything back to normal. Alright, as a quick recap. In type 1 diabetes, there's an absolute insulin deficiency, and lab tests will show high GAD and ICA2 antibody titers, and low C-peptide levels. In type 2 diabetes, there's elevated blood glucose levels and an HbA1c above 6.5%. Most of the time, initial treatment for type 2 diabetes is lifestyle changes with or without metformin. And the goal is to get that HbA1c down below 7%, and additional medications can be used to accomplish that. For individuals with type 2 diabetes who aren't able to get by on these additional medications, and for those with type 1 diabetes, insulin therapy is used. Typically, insulin is given as a basal bolus scheme. That is, 1 long-acting insulin before bedtime and 3 rapid-acting insulins before each meal. A serious complication of anti-diabetic treatment is hypoglycemia, which is when blood sugar drops below 70 milligrams per deciliter. And it's treated with either oral or intravenous glucose, depending on a person's consciousness. At the other end of the spectrum, we've got the hyperglycemic complications of diabetes, diabetic ketoacidosis, more frequent in type 1, which is treated with intravenous fluids, insulin and potassium, and hyperosmolar hyperglycemic state, more frequent in type 2, which is treated with intravenous fluids and insulin.
In the emergency department, 2 individuals came in. One of them is 12-year-old Timmy, who is severely dehydrated, presents with rapid and deep breaths, abdominal pain, nausea, and vomiting. On the clinical examination, his breath actually smells fruity and sweet. Timmy's parents say that he'd been eating a lot, but he'd actually lost a lot of weight. Also, they said that Timmy is also drinking water all the time and going to the bathroom a lot. The other person is 55-year-old Oliver, who also came in with severe dehydration, lethargy, and his family said he had a seizure about 2 hours ago. In the past month, he had lost some weight, although he had been eating. Both individuals underwent several investigations, including glucose levels, ketone bodies BMP, and an ABG. Based on both individuals' symptoms, we can assume that both suffer from diabetes mellitus. Diabetes mellitus is a condition where glucose can't be properly moved through the blood into the cells. This leads to high levels of glucose in the blood and not enough of it inside cells. Since cells need glucose as a source of energy, not letting glucose enter means that the cells starve for energy despite having glucose right on their doorstep. In general, the body controls how much glucose is in the blood with 2 hormones, insulin and glucagon. Both of these hormones are produced in the islets of Langerhans of the pancreas. Insulin is secreted by the beta cells, while glucagon is secreted by the alpha cells. Insulin reduces blood glucose levels. It does that by binding to insulin receptors embedded in the cell membrane of insulin-responsive tissues, like muscle cells and adipose tissue. When activated, the insulin receptors cause vesicles containing the glucose transporter that are inside the cell to fuse with the cell membrane, allowing glucose to be transported into the cell. Now, there are 2 types of diabetes mellitus, type 1 and type 2, and the main difference between them is the underlying mechanism that causes the blood glucose levels to rise. Let's start with type 1 diabetes mellitus, which is an autoimmune condition. See, autoimmune conditions sometimes happen together. So on the exam, the past medical history might include a history of autoimmune thyroid disease, like Hashimoto's thyroiditis, or vitiligo, or lupus. In type 1 diabetes, the immune system targets and destroys the beta cells of the pancreas. A common target is an enzyme inside beta cells called glutamic acid decarboxylase, which helps make gamma-aminobutyric acid, or GABA, which, among others, increases insulin release and also has a protective and regenerative effect on the beta cells. The high-yield fact to remember is that the antibodies against glutamic acid decarboxylase are called GAD antibodies. In addition, other antibodies like anti-islet cell antibodies can also be present. Without the protective and regenerative effect of GABA, the beta cells progressively decrease. Losing beta cells means less insulin, and less insulin means that glucose builds up in the blood, because it can't enter the body's cells. Now, there is a gene complex involved in the regulation of the immune response, and this is called the human leukocyte antigen system, or HLA system. These genes code for the major histocompatibility complex, or MHC, which is a protein that's extremely important in helping the immune system recognize foreign molecules, as well as maintaining self-tolerance. MHC is like the serving platter that antigens are presented to the immune cells. Interestingly, people with type 1 diabetes often have specific HLA genes in common, HLA-DR3 and HLA-DR4, both of which are high yield for your exams. In diabetes mellitus type 1, destruction of beta cells usually starts early in life, and individuals present with symptoms of diabetes before the age of 30. In type 1 diabetes, the tissues are very sensitive to insulin, but since there are less beta cells, insulin levels are low. On histology, there's usually an islet leukocytic infiltrate. There are 4 clinical symptoms of uncontrolled diabetes. There's polyphagia, glycosuria, polyuria, and polydipsia. Let's go through them one by one. Even though there's a lot of glucose in the blood, it can't get into cells, which leaves cells starved for energy. So, in response, adipose tissue starts breaking down fat, called lipolysis, and muscle tissue starts breaking down proteins, called proteolysis, both of which results in weight loss for someone with uncontrolled diabetes. This catabolism leads to polyphagia. Now, with high glucose levels, when blood gets filtered through the kidneys, some of it starts to spill into the urine, and this is called glycosuria. Since glucose is osmotically active, water tends to follow it, resulting in an increase in urination, or polyuria. Finally, because there's so much urination, people with uncontrolled diabetes become dehydrated, resulting in polydipsia. Now, let's move on to type 2 diabetes mellitus. In type 2 diabetes, the body makes insulin, but the tissues don't respond to it as well. The exact reason why cells don't respond isn't fully understood. Essentially, the body's providing the normal amount of insulin, but the cells don't move their glucose transporters to the membrane. This is called insulin resistance. The most important risk factor for insulin resistance is obesity. Apart from this, there are also some genetic factors involved. We see this when we look at twin studies as well, where having a twin with type 2 diabetes increases the risk of developing type 2 diabetes, completely independent of other environmental risk factors. In type 2 diabetes, since tissues don't respond as well to normal levels of insulin, the body ends up producing more insulin in order to get the same effect and move glucose out of the blood. This works for a while, and by keeping insulin levels higher than normal, blood glucose levels can be kept normal. This beta cell compensation, though, isn't sustainable, and over time, these overworked beta cells get exhausted and eventually die off. When this happens, insulin levels will start decreasing. So remember that the serum levels of insulin in type 2 diabetes is variable depending on when it's diagnosed. Now, along with insulin, beta cells also secrete amyloid polypeptide. So while beta cells are cranking out insulin, they also secrete an increased amount of amyloid polypeptide. Over time, amyloid polypeptide builds up and aggregates in the islets. So on histology, there will be amyloid polypeptide deposits in the pancreas, along with a variable number of beta cells, depending on when it's diagnosed. Now, type 2 diabetes usually appears after the age of 40, and presents similarly as type 1 diabetes with polydipsia, polyuria, polyphagia, and weight loss. Diagnosing type 1 or type 2 diabetes is done by getting a sense for how much glucose is floating around in the blood. Very commonly, a fasting glucose test is taken, where the person doesn't eat or drink, except water, that's okay, for 8 hours, and has their blood tested for glucose levels. A level of 126 milligrams per deciliter or higher indicates diabetes. A non-fasting or random glucose test can be done at any time, with 200 milligrams per deciliter or higher being diagnostic for diabetes if the individual has symptoms. Another test is called an oral glucose tolerance test, where a person is given glucose and then blood samples are taken at time intervals to figure out how well it's being cleared from the blood. A glucose level over 200 milligrams per deciliter after 2 hours indicates diabetes. Okay, so when blood glucose levels get high, the glucose can also stick to proteins that are floating around in the blood or cells. So that brings us to the HbA1c test, which tests for the proportion of hemoglobin in red blood cells that have glucose stuck to it, or glycated hemoglobin. HbA1c levels of 6.5% or higher indicates diabetes. This proportion of glycated hemoglobin doesn't change day to day. So a high-yield fact is that this test gives a sense for whether the blood glucose levels have been high over the past 3 months, which is the lifespan of a typical red blood cell. Regarding treatment, in type 1 diabetes, insulin is always necessary because of decreased endogenous production. While in type 2 diabetes, lifestyle modifications like exercise and dietary changes are first line. In addition, oral medications like metformin are the first-line pharmacologic intervention in type 2 diabetes, with insulin being an option if oral medications fail to control glucose levels. It's also important to treat and prevent complications in diabetes. For example, ACE inhibitors and ARBs have been shown to decrease the risk of diabetic nephropathy in diabetic individuals with hypertension. In addition, yearly eye exams, urine microalbumin testing, and foot exams should be done. Now, let's go over one very high-yield acute complication of diabetes that usually happens with type 1 diabetes, and it's called diabetic ketoacidosis, or DKA. This usually happens when individuals aren't rigorous with their insulin therapy, or when the body is really stressed and needs more insulin, like during an infection. To understand it, let's go back to the process of lipolysis, where fat is broken down into free fatty acids. After that happens, the liver turns the fatty acids into ketone bodies, like acetoacetic acid and beta-hydroxybutyric acid. These ketone bodies are important because they can be used by cells for energy, but they also increase the acidity of the blood, which is why it's called ketoacidosis, which is a type of metabolic acidosis. Now, this doesn't typically happen in type 2 diabetes because there's usually some level of endogenous insulin that prevents lipolysis. Clinically, individuals with DKA are dehydrated because a lot of glucose is lost through urine, and they can develop Kussmaul respiration, which is a deep and rapid breathing as the body tries to move carbon dioxide out of the blood in an effort to reduce its acidity. Their breath also smells sweet and fruity because ketone bodies break down into acetone, which escape as a gas during exhalation. Abdominal pain, nausea, vomiting, and in severe DKA, mental status changes like delirium and psychosis can occur. Complications of DKA include acute cerebral edema, which is when there's too much fluid in the intra- or extracellular space. In the case of DKA, there's too much fluid in the extracellular space of the brain because glucose basically drags water out of the cells. Other complications include cardiac arrhythmias due to potassium imbalance, which can lead to heart failure. And finally, since people with DKA have poorly controlled diabetes, their immune system is also likely to be compromised. This means they are more vulnerable to common infections like Candida, but also some that only affects people with immune deficiencies. One of these is mucormycosis, a life-threatening fungal infection caused by Rhizopus species that starts in the sinuses but can spread to the brain. Lab results show hyperglycemia and signs of metabolic acidosis, which is low pH levels and low levels of bicarbonate, or HCO3. The anion gap is high, which reflects a large difference in the unmeasured negative and positive ions in the serum, largely due to this buildup of keto acids. Blood ketone levels are also high, and if there's a concomitant infection, then leukocytosis can also be present. Now let's focus a bit for the next part. Cells have a transporter that exchanges hydrogen ions for potassium. When the blood gets acidic, there's a lot of positively charged hydrogen ions floating around. Cells will exchange these extracellular protons with intracellular potassium. So at first, there will be hyperkalemia. Next, in addition to helping glucose enter cells, insulin also stimulates the sodium-potassium ATPases, which help potassium get into cells. And so without insulin, more potassium stays in the extracellular fluid. Since all this potassium is eventually excreted, even though the blood potassium levels remain high, overall stores of potassium in the body starts to run low, and in this way, total body potassium is depleted. Treatment of DKA relies on IV fluids to correct dehydration, IV insulin, and potassium. Sometimes to prevent overcorrecting the hyperglycemia, a small amount of dextrose is given with the insulin. One high-yield acute complication that usually happens with type 2 diabetes is hyperosmolar hyperglycemic state, which is when levels of glucose are really high and it leads to extreme dehydration. To help understand this, remember that glucose is a polar molecule that cannot passively diffuse across cell membranes, which means that it acts as a solute. So, when levels of glucose are super high in the body, that means it's in a hyperosmolar state. So water begins to leave the body's cells and enter the blood vessels, leaving the cells relatively dry and shriveled. Blood vessels that are full of water leads to polyuria and dehydration. And this is a very serious situation because severe dehydration affects the brain, leading to various symptoms like lethargy and focal neurological deficits like seizures, which can progress to coma and death if left untreated. Labs show hyperglycemia, often over 600 milligrams per deciliter, high serum osmolality, often over 320 milliosmoles per kilogram, and, unlike DKA, there's no acidosis, because ketone production is limited by the endogenous insulin. Treatment relies on a lot of IV fluids and insulin therapy. Another important complication associated with the treatment of diabetes is hypoglycemia. This is usually related to insulin, but can also be caused by oral medications, like sulfonylureas. Recall that the brain depends on glucose for its energy, so hypoglycemia is extremely dangerous, as it can lead to irreversible damage to the neurons. The symptoms of hypoglycemia include symptoms of autonomic system activation, such as palpitations, sweating, shaking, nausea, and of course hunger. The more dangerous symptoms are called neuroglycopenic symptoms, which include focal neurological deficit, mental confusion, and coma. Now, exams like to test your ability to differentiate hypoglycemia caused by injecting insulin from that caused by insulomas or sulfonylureas. To do this, we measure serum levels of insulin and C-peptide, an endogenous byproduct of insulin production in the beta cells. High insulin levels but low C-peptide means the hypoglycemia is caused by exogenous insulin. On the other hand, high insulin and high C-peptide levels indicate that the problem is coming from an insulinoma, an insulin-producing beta cell tumor. Sulfonylureas also result in a similar biochemical profile, since they increase endogenous beta cell production of insulin along with C-peptide levels. Now, there are some chronic complications of diabetes, which can happen with both type 1 and type 2 diabetes. The two basic mechanisms are non-enzymatic glycosylation, or NEG, and osmotic cellular damage. Non-enzymatic glycosylation occurs when glucose covalently attaches to cell proteins and lipids, without the help of an enzyme. These sugar-coated molecules are pro-inflammatory and can cause damage to the cell. NEG in small blood vessels like arterioles can cause hyaline arteriolosclerosis, where the walls of arterioles develop protein deposits that make them hard and inflexible. In addition, the basement membrane can thicken and make it hard for oxygen to easily move into the tissues, causing hypoxia. In the eyes, it can lead to retinopathy. A fundoscopic exam will show cotton wool spots, flame hemorrhages, and microaneurysms. In the kidneys, the afferent and efferent arterioles, as well as the glomerulus itself, can get damaged, which can lead to nodular glomerulosclerosis. On histology, there's Kimmel-Steele-Wilson nodules, which are clumps of hyaline material found in glomerular capillaries. In the early stages of diabetic nephropathy, small amounts of albumin leak through the glomerular barrier and into the urine. This is called microalbuminuria, and it's the earliest sign of diabetic nephropathy, which can eventually progress to chronic kidney disease. When NEG occurs in medium and large arterial walls, it can lead to atherosclerosis, which can affect multiple vessels, like the coronary arteries of the heart, causing coronary artery disease, or CAD. This is the major cause of death in diabetics. It can also affect the arteries in the legs, causing peripheral vascular occlusive disease, which can lead to gangrene and even limb loss. Finally, it can affect the tiny arteries in the brain, leading to cerebrovascular disease and strokes. The next mechanism is osmotic cellular damage. Normally, when glucose enters cells, it can be converted into an alcohol called sorbitol by the enzyme aldose reductase. The problem is that sorbitol is an osmotic agent, meaning it attracts water, but here the water is going into the cells. As a protective mechanism, some cells are able to convert sorbitol to fructose with the enzyme sorbitol dehydrogenase. But the cells of the lens, the pericytes in the retina, Schwann cells, and renal epithelial cells lack this enzyme. So in the lens, sorbitol builds up, causing cataracts. Damage to the Schwann cells decreases the myelination of sensory and autonomic nerve fibers, causing diabetic neuropathy, which manifests in a stocking glove distribution. This makes these parts of the body more prone to injury, and they can often develop foot ulcers as a result of chronic damage. This is made worse by the fact that they will also have impaired healing due to hyperglycemia. Autonomic neuropathy can cause diabetic gastroparesis, which is weakness of the gastric peristalsis that results in vomiting after meals and constipation. Besides type 1 and type 2 diabetes, there are also a couple of other subtypes of diabetes mellitus. An important one that's commonly tested is gestational diabetes, which is when pregnant women have increased blood glucose, especially during the third trimester. This occurs because the placenta releases large amounts of human placental lactogen, which is thought to induce insulin resistance. Some mothers might not be able to produce enough insulin to overcome the effect of this placental hormone, so blood glucose goes up and signs of diabetes manifests. Diabetes can also occur secondary to some systemic disorders, like Cushing's syndrome, and medications like glucocorticoids. This is because corticosteroids also cause insulin resistance. Alright, as a quick recap, type 1 diabetes mellitus is an autoimmune condition that's associated with HLA-DR3 and DR4. It causes the destruction of beta cells by autoantibodies, and this usually starts before the age of 30. The tissues are very sensitive to insulin, but insulin levels are low. In type 2 diabetes mellitus, there's insulin resistance. Risk factors for type 2 diabetes are obesity and various genetic factors. Insulin levels are increased at the start, but as the islet cells tire out and die, the level drops. Type 2 diabetes usually manifests after the age of 40 and presents similarly as type 1 diabetes with symptoms like glucoseuria, polyuria, polydipsia, polyphagia, and unintentional weight loss. To diagnose diabetes, a fasting glucose, a non-fasting glucose, or the oral glucose tolerance test can be done. However, HbA1c gives a better sense of blood glucose levels over the past 3 months. One important acute complication of type 1 diabetes is DKA, which presents with dehydration, Kussmaul respiration, sweet and fruity breath, abdominal pain, nausea, vomiting, and mental status changes like delirium and psychosis. These people will have metabolic acidosis and hyperkalemia with reduced total body potassium. An acute complication of type 2 diabetes is hyperosmolar hyperglycemic state, characterized by dehydration due to high serum osmolality. The cause is severe hyperglycemia, but there's no metabolic acidosis since ketones are not generated. Some of the important chronic complications of diabetes include small vessel disease, which can affect the eyes or the kidneys, atherosclerosis, which can lead to CAD, peripheral vascular occlusive disease, and cerebrovascular disease, and neurological problems like paresthesia in a glove and stocking distribution. Okay, back to our cases. Timmy came in severely dehydrated, and he had rapid and deep breaths, which is indicative of Kussmaul respiration. His breath had a sweet and fruity odor due to acetone from ketone body metabolism. All of these point to DKA. The lab results showing high levels of glucose, low pH with low bicarbonate levels, and a high anion gap, increased blood ketone levels, and hyperkalemia confirms this. His parents said that he's been eating a lot lately, but actually lost weight, meaning he has polyphagia with weight loss. He also had polydipsia and polyuria, and these are all symptoms of diabetes mellitus. Due to his age and the presence of DKA, he most likely has a cause of previously undiagnosed type 1 diabetes. Now, Timmy has received a lot of fluids and insulin, and after making him feel better, more tests have been done, like a fasting glucose and GAD antibodies test to confirm the diagnosis. Next, we have Oliver, who came in with severe dehydration, lethargy, and seizures. Labs show really high levels of glucose, above 600 milligrams per deciliter, but no acidosis or ketone bodies. His serum osmolality was over 320 milliosmoles per kilogram. All this indicates hyperosmolar hyperglycemic coma, which is usually a complication of type 2 diabetes. Oliver has been treated with IV fluids and insulin with dextrose. Further tests like a fasting glucose and HbA1c test need to be done to confirm type 2 diabetes.
In diabetes mellitus, your body has trouble moving glucose, which is a type of sugar, from your blood into your cells. This leads to high levels of glucose in your blood and not enough of it in your cells. And remember that your cells need glucose as a source of energy. So not letting the glucose enter means that the cells starve for energy, despite having glucose right on their doorstep. In general, the body controls how much glucose is in the blood relative to how much gets into the cells with two hormones, insulin and glucagon. Insulin is used to reduce blood glucose levels, and glucagon is used to increase blood glucose levels. Both of these hormones are produced by clusters of cells in the pancreas called islets of Langerhans. Insulin is secreted by beta cells in the center of these islets, and glucagon is secreted by alpha cells in the periphery of the islets. Insulin reduces the amount of glucose in the blood by binding to insulin receptors embedded in the cell membrane of various insulin-responsive tissues, like muscle cells and adipose tissue. When activated, the insulin receptors cause vesicles containing glucose transporter that are inside the cell to fuse with the cell membrane, allowing glucose to be transported into the cell. Glucagon does exactly the opposite. It raises the blood glucose levels by getting the liver to generate new molecules of glucose from other molecules, and also break down glycogen into glucose so that it can all get dumped into the blood. Diabetes mellitus is diagnosed when blood glucose levels get too high, and this is seen among 10% of the world population. There are two types of diabetes, type 1 and type 2, and the main difference between them is the underlying mechanism that causes the blood glucose levels to rise. About 10% of people with diabetes have type 1, and the remaining 90% of people with diabetes have type 2. Let's start with type 1 diabetes mellitus, sometimes just called type 1 diabetes. In this situation, the body doesn't make enough insulin. The reason this happens is that in type 1 diabetes, there's a type 4 hypersensitivity response, or a cell-mediated immune response, where a person's own T cells attack the pancreas. As a quick review, remember that the immune system has T cells that react to all sorts of antigens, which are usually small peptides, polysaccharides, or lipids, and that some of these antigens are part of our own body's cells. It doesn't make sense to allow T cells that will attack our own cells to hang around. And so there's this process to eliminate them called self-tolerance. In type 1 diabetes, there's a genetic abnormality that causes a loss of self-tolerance among T cells that specifically target the beta cell antigens. Losing self-tolerance means that these T cells are allowed to recruit other immune cells and coordinate an attack on these beta cells. Losing beta cells means less insulin, and less insulin means that glucose piles up in the blood, because it can't enter the body's cells. One really important group of genes involved in regulation of the immune response is the human leukocyte antigen system, or HLA system. Even though it's called a system, it's basically this group of genes on chromosome 6 that encode the major histocompatibility complex, or MHC, which is a protein that's extremely important in helping the immune system recognize foreign molecules, as well as maintaining self-tolerance. MHC is like the serving platter that antigens are presented to the immune cells on. Interestingly, people with type 1 diabetes often have specific HLA genes in common with each other. One called HLA-DR3 and another called HLA-DR4. But this is just a genetic clue, right? Because not everyone with HLA-DR3 and HLA-DR4 develops diabetes. In diabetes mellitus type 1, destruction of beta cells usually starts early in life, but sometimes up to 90% of the beta cells are destroyed before symptoms crop up. 4 clinical symptoms of uncontrolled diabetes that all sound similar are polyphagia, glycosuria, polyuria, and polydipsia. Let's go through them one by one. Even though there's a lot of glucose in the blood, it cannot get into the cells, which leaves cells starved for energy. So in response, adipose tissue starts breaking down fat, called lipolysis, and muscle tissue starts breaking down proteins, both of which result in weight loss for someone with uncontrolled diabetes. This catabolic state leaves people feeling hungry, also known as polyphagia. Phagia means eating, and poly means a lot. Now, with high glucose levels, that means that when blood gets filtered through the kidneys, some of it starts to spill into the urine, called glycosuria. Glycose refers to glucose, and urea, the urine. Since glucose is osmotically active, water tends to follow it, resulting in an increase in urination, or polyuria. Poly again refers to a lot, and urea again refers to urine. Finally, because there's so much urination, people with uncontrolled diabetes become dehydrated and thirsty, or polydipsia. Poly means a lot, and dipsia means thirst. Even though people with diabetes are not able to produce their own insulin, they can still respond to insulin. So treatment involves lifelong insulin therapy to regulate their blood glucose levels and basically enable their cells to use glucose. One really serious complication with type 1 diabetes is called diabetic ketoacidosis, or DKA. To understand it, let's go back to the process of lipolysis, where fat is broken down into free fatty acids. After that happens, the liver turns the fatty acids into ketone bodies. like acetoacetic acid and beta-hydroxybutyric acid. Acetoacetic acid is a keto acid because it has a ketone group and a carboxylic acid group. Beta-hydroxybutyric acid, on the other hand, even though it's still one of the ketone bodies, isn't technically a keto acid, since its ketone group has been reduced to a hydroxyl group. These ketone bodies are important because they can be used by cells for energy, but they also increase the acidity of the blood, which is why it's called ketoacidosis. And the blood becoming really acidic can have major effects throughout the body. Individuals can develop Kussmaul respiration, which is a deep and labored breathing as the body tries to move carbon dioxide out of the blood, in an effort to reduce its acidity. Cells also have a transporter that exchanges hydrogen ions, or protons, for potassium. When the blood gets acidic, it's by definition loaded with protons that get sent into cells while potassium gets sent into the fluid outside cells. Another thing to keep in mind is that in addition to helping glucose enter cells, insulin stimulates the sodium-potassium ATPases, which help potassium get into the cells. And so without insulin, more potassium stays in the fluid outside cells. Both of these mechanisms lead to increased potassium in the fluid outside cells, which quickly makes it into the blood and causes hyperkalemia. The potassium is then excreted. So over time, even though the blood potassium levels remain high, overall stores of potassium in the body, which include potassium inside cells, starts to run low. Individuals will also have a high anion gap, which reflects a large difference in the unmeasured negative and positive ions in the serum, largely due to the buildup of keto acids. Diabetic ketoacidosis can happen even in people who've already been diagnosed with diabetes and currently have some sort of insulin therapy. In states of stress, like an infection, the body releases epinephrine, which in turn stimulates the release of glucagon. Too much glucagon can tip the delicate hormonal balance of glucagon and insulin in favor of elevating blood sugars and can lead to a cascade of events we just described: increased glucose in the blood, loss of glucose in the urine, loss of water, dehydration, and in parallel, a need for alternative energy, generation of ketone bodies, and ketoacidosis. Interestingly, both ketone bodies break down into acetone and escape as a gas by getting breathed out the lungs, which gives a sweet, fruity smell to a person's breath. In general, though, that's the only sweet thing about this illness, which also causes nausea, vomiting, and if severe, mental status changes and acute cerebral edema. Treatment of a DKA episode involves giving plenty of fluids, which helps with dehydration, insulin, which helps lower blood glucose levels, and replacement of electrolytes, like potassium, all of which help to reverse the acidosis. Now let's switch gears and talk about type 2 diabetes, which is where the body makes insulin, but the tissues don't respond as well to it. The exact reason why cells don't respond isn't fully understood. Essentially, the body's providing the normal amount of insulin, but the cells don't move their glucose transporters to their membrane in response, which remember is needed for the glucose to get into the cells. These cells therefore have insulin resistance. Some risk factors for insulin resistance are obesity, lack of exercise, and hypertension, and the exact mechanisms are still being explored. For example, an excess of adipose tissue, or fat, is thought to cause the release of free fatty acids and so-called adipokines, which are signaling molecules that can cause inflammation, which seems related to insulin resistance. However, many people that are obese are not diabetic, so genetic factors probably play a major role as well. We see this when we look at twin studies as well, where having a twin with type 2 diabetes increases the risk of developing type 2 diabetes, completely independently of other environmental risk factors. In type 2 diabetes, since tissues don't respond as well to normal levels of insulin, the body ends up producing more insulin in order to get the same effect and move glucose out of the blood. They do this through beta cell hyperplasia, an increased number of beta cells, and beta cell hypertrophy, where they actually grow in size, all in this attempt to pump out more insulin. This works for a while, and by keeping insulin levels higher than normal, blood glucose levels can be kept normal, called normoglycemia. Now, along with insulin, beta cells also secrete islet amyloid polypeptide, or amylin. So while beta cells are cranking out insulin, they also secrete an increased amount of amylin. Over time, amylin builds up and aggregates in the islets. This beta cell compensation, though, is not sustainable. And over time, those maxed out beta cells get exhausted, and they become dysfunctional, and undergo hypertrophy, and get smaller, as well as hypoplasia and die off. As beta cells are lost and insulin levels decrease, glucose levels in the blood start to increase, and patients develop hyperglycemia, which leads to similar clinical signs that we mentioned before, like polyphagia, glycosuria, polyuria, and polydipsia. But unlike type 1 diabetes, there's generally some circulating insulin in type 2 diabetes from the beta cells that are trying to compensate for the insulin resistance. This means that the insulin-glucagon balance is such that diabetic ketoacidosis does not usually develop. Having said that, a complication called hyperosmolar hyperglycemic state, or HHS, is much more common in type 2 diabetes than type 1 diabetes. And it causes increased plasma osmolarity due to extreme dehydration and concentration of the blood. To help understand this, remember that glucose is a polar molecule that cannot passively diffuse across cell membranes, which means that it acts as a solute. So when levels of glucose are super high in the blood, meaning it's a hyperosmolar state, water starts to leave the body's cells and enter the blood vessels, leaving the cells relatively dry and shriveled, rather than plump and juicy. Blood vessels that are full of water lead to increased urination and total body dehydration. And this is a very serious situation, because the dehydration of the body's cells, and in particular the brain, can cause a number of symptoms, including mental status changes. In HHS, you can sometimes see mild ketonemia and acidosis, but not to the extent that it's seen in DKA. And in DKA, you can see some hyperosmolarity, so there's definitely overlap between these two syndromes. Besides type 1 and type 2 diabetes, there are also a couple other subtypes of diabetes mellitus. Gestational diabetes is when pregnant women have increased blood glucose, which is particularly during the third trimester. Although ultimately unknown, the cause is thought to be related to pregnancy hormones that interfere with insulin's action on insulin receptors. Also, sometimes people can develop drug-induced diabetes, which is where medications have side effects that tend to increase blood glucose levels. The mechanism for both of these is thought to be related to insulin resistance, like type 2 diabetes, rather than an autoimmune destruction process like in type 1 diabetes. Diagnosing type 1 or type 2 diabetes is done by getting a sense for how much glucose is floating around in the blood, and has specific standards that the World Health Organization uses. Very commonly, a fasting glucose test is taken where the person doesn't eat or drink, except water, that's okay, for a total of 8 hours, and then has their blood tested for glucose levels. Levels of 100 milligrams per deciliter to 125 milligrams per deciliter indicates prediabetes, and 126 milligrams per deciliter or higher indicates diabetes. A non-fasting or random glucose test can be done at any time, with 200 milligrams per deciliter or higher being a red flag for diabetes. Another test is called an oral glucose tolerance test, where a person is given glucose, and then blood samples are taken at time intervals to figure out how well it's being cleared from the blood, the most important interval being 2 hours later. Levels of 140 milligrams per deciliter to 199 milligrams per deciliter indicate prediabetes, and 200 or above indicates diabetes. Another thing to know is that when blood glucose levels get high, the glucose can also stick to proteins that are floating around in the blood or in cells. So that brings us to another type of test that can be done, which is the HbA1c test, which tests for the proportion of hemoglobin in red blood cells that has glucose stuck to it, called glycated hemoglobin. HbA1c levels of 5.7% to 6.4% indicate prediabetes, and 6.5% or higher indicates diabetes. This proportion of glycated hemoglobin doesn't change day to day, so it gives a sense for whether the blood glucose levels have been high over the past 2 to 3 months. Finally, we have the C-peptide test, which tests for byproducts of insulin production. If the level of C-peptide is low or absent, it means the pancreas is no longer producing enough insulin, and the glucose cannot enter the cells. For type 1 diabetes, insulin is the only treatment option. For type 2 diabetes, on the other hand, lifestyle changes like weight loss and exercise, along with a healthy diet and oral anti-diabetic medication, like metformin and several other classes, can sometimes be enough to reverse some of that insulin resistance and keep blood sugar levels in check. However, if oral anti-diabetic medications fail, type 2 diabetes can also be treated with insulin. Something to bear in mind is that insulin treatment comes with a risk of hypoglycemia, especially if insulin is taken without a meal. Symptoms of hypoglycemia can be mild, like weakness, hunger, and shaking, but they can progress to a loss of consciousness and seizures in severe cases. In mild cases, drinking juices or eating candy or sugar might be enough to bring blood sugar up. But in severe cases, intravenous glucose should be given as soon as possible. The FDA has also recently approved intranasal glucagon as a treatment for severe hypoglycemia. Alright, now over time, high glucose levels can cause damage to tiny blood vessels, called the microvasculature. In arterioles, a process called hyaline arteriolosclerosis is where the walls of the arterioles develop hyaline deposits, which are deposits of proteins, and these make them hard and inflexible. In capillaries, the basement membrane can thicken and make it difficult for oxygen to easily move from the capillary to the tissues, causing hypoxia. One of the most significant effects is that diabetes increases the risk of medium and large arterial wall damage and subsequent atherosclerosis, which can lead to heart attacks and strokes, which are major causes of morbidity and mortality for patients with diabetes. In the eyes, diabetes can lead to retinopathy, and evidence of that can be seen on a fundoscopic exam that shows cotton wool spots or flare hemorrhages, and can eventually cause blindness. In the kidneys, the afferent and efferent arterioles, as well as the glomerulus itself, can get damaged, which can lead to a nephrotic syndrome that slowly diminishes the kidney's ability to filter blood over time, and can ultimately lead to dialysis. Diabetes can also affect the function of nerves, causing symptoms like a decrease in sensation in the toes and fingers, sometimes called the stocking glove distribution, as well as causes the autonomic nervous system to malfunction. And that system controls a number of body functions, everything from sweating to passing gas. Finally, both the poor blood supply and nerve damage can lead to ulcers, typically on the feet, that don't heal quickly and can get pretty severe and need to be amputated. These are some of the complications of uncontrolled diabetes, which is why it's important to diagnose and control diabetes through a healthy lifestyle, medications to reduce insulin resistance, and even insulin therapy if beta cells have been exhausted. While type 1 diabetes cannot be prevented, type 2 diabetes can. In fact, many people with diabetes can control their blood sugar levels really effectively and live a full and active life without any of the complications. Diabetic nephropathy refers to the kidney damage caused by both type 1 and type 2 diabetes. Because of the growing number of people affected by diabetes, diabetic nephropathy is currently the leading cause of end-stage renal disease in most developed countries around the world. Each kidney has millions of nephrons, each of which is served by a tiny capillary bed called a glomerulus. The tiny arteriole that approaches the glomerulus is called the afferent arteriole, A for approaching, and the arteriole that exits the glomerulus is called the efferent arteriole, E for exits. The glomeruli are a tiny cluster of capillaries that are physically supported by mesangial cells. So when blood is filtered, it moves through the endothelium lining the capillary, then through the basement membrane, and then through the epithelium lining the nephron, and finally into the nephron itself, at which point it's called filtrate. Now, the endothelium has pores that keep cells from entering the filtrate, and the basement membrane's negatively charged and repels other negatively charged molecules and proteins, like the protein albumin. Furthermore, the epithelium has a special cell type called a podocyte, which looks like an octopus because it has foot processes that wrap around the basement membrane, which leaves tiny gaps between its octopus-like projections called filtration slits. In diabetes mellitus, there's an excess of glucose in the blood because it can't get into cells. And when blood gets filtered through the kidneys, some of that excess glucose starts to spill into the urine, called glycosuria. In addition, when there's a lot of glucose in the blood, it also starts sticking to proteins in the blood, a process called non-enzymatic glycation, because no enzymes are involved. Because glucose can get through the endothelium, this process of glycation can also involve the basement membrane of small blood vessels, which makes it thicken. The process particularly affects the efferent arteriole, causing it to get stiff and more narrow, a process called hyaline arteriosclerosis. This creates an obstruction that makes it difficult for blood to leave the glomerulus, which increases pressure within that glomerulus. At the same time, the afferent arteriole dilates, which allows more blood flow into the glomerulus and increases pressure even more. High pressure in the glomerulus leads to an increase in the glomerular filtration rate, which is just the amount of blood filtered through per minute. And this is the first stage of diabetic nephropathy, called hyperfiltration. In response to this high pressure state, the supportive mesangial cells secrete more and more structural matrix, which expands the size of the glomerulus. This matrix deposition and mesangial expansion can happen uniformly, or it can result in little nodules within the mesangium, called Kimmel-Steele-Wilson nodules, which are tiny balls of protein. The thickening of the basement membrane counterintuitively makes it more permeable, allowing proteins like albumin through that otherwise would have been filtered out. It makes sense though if you think about our octopus friend again. As the glomerulus expands, the legs of the octopus naturally have larger gaps between them. In other words, the filtration slits widen, making it easier for substances to slip through. So in the end, the key abnormalities in diabetic nephropathy are a thickened glomerular basement membrane, mesangial expansion, Kimmel-Steele-Wilson nodules, and disruption of the podocytes. Eventually, these changes damage the glomerulus so much that it's unable to filter blood normally, and the glomerular filtration rate decreases. Typically, diabetic nephropathy starts quietly, with no symptoms during the hyperfiltration phase. But over time, as more and more of the nephrons are affected, the kidney becomes less and less effective at filtering the blood into the urine, and the glomerular filtration rate decreases dramatically. Once the kidneys no longer can do their job of filtering the blood, a person enters into end-stage renal disease. Because there are no overt symptoms of diabetic nephropathy, regularly screening the urine of individuals with diabetes is super important. Microalbuminuria, which means excreting 30 to 300 milligrams of albumin in a day, is a reliable signal that diabetic nephropathy has started to set in. Excreting above 300 milligrams per day is considered macroalbuminuria and is a sure sign of a problem. Unfortunately, diabetic nephropathy is a progressive complication that can be significantly slowed down, but not completely stopped. Keeping tight control on hypertension and hyperglycemia is critical. Specifically, angiotensin-converting enzyme inhibitors, or ACE inhibitors, as well as angiotensin receptor blockers can be particularly useful. These not only lower blood pressure as a whole, but they also specifically reduce constriction of the efferent arteriole. By reducing this constriction, we reduce the pressure within the glomerulus, as well as the damage that comes from it. Alright, as a quick recap, diabetic nephropathy is kidney damage that's caused by diabetes, which results in glomerular basement membrane thickening, mesangial expansion, and sclerosis. An initial phase of increased glomerular filtration rate is followed by progressive albuminuria, then a gradual decline in glomerular filtration rate, and finally renal failure. This progression can be slowed by tight control of blood sugar and blood pressure, and the use of ACE inhibitors or angiotensin receptor blockers to decrease pressure specifically within the glomerulus.
Hey everybody, my name's Kyle. I'm one of the team members here at Osmosis. I do a little bit of everything for content, so I've done a little bit of script writing, I've done some voiceovers, I've done some video editing, reviewed some of the videos too, but mostly I'm a project manager, so I help make sure that the whole bus doesn't go flying off the road. And I do work on our internationalization, so if you've been noticing there's a lot of foreign language translations, that's thanks to Translators Without Borders and a lot of people like you on YouTube who have come in to try and help get our videos out to as many people as possible in different languages. So thanks for all your hard work. That's really meant a lot to us. I wanted just to give a quick shout out to Krista Morris, who wrote the script for this video, and of course Rishi for reviewing it and editing it, and Tanner for doing the illustrations. Also, don't forget to check out, I think on our social media. We have Instagram, we have Facebook, we have Twitter. We have a new Reddit channel that you can go and start having conversations. We post all of our new videos there. And then, yeah, don't forget to check us out on Patreon and consider donating to help us make more videos. Thanks so much.